I'm excited to introduce you to Dr. Andrea Green, Professor of Pediatrics at the University of Vermont's Larner College of Medicine. She is the director of the Pediatric New American Program and Pediatric Global Health, where her focus is on providing care to children in immigrant families. Areas of academic focus include mental health screening and multigenerational trauma, social determinants of health, especially around food insecurity and non-traditional U.S. diets, health literacy, care coordination, community collaboration, and advocacy. Thank you, Dr. Green, for being with us today. Hold on one moment. We've got to get you unmuted.
Can you hear me?
Yes.
Perfect. Thank you very much. I appreciate so much this opportunity to be here and to talk to you all about a child's team huddle, or a care conference, which we call a tool for family-centered care. First off, I want to say that I have nothing to disclose, and I do not intend to talk about anything that is not okay to discuss. Today, we're going to talk about a few things, and I am going to talk slowly, and I'm going to pause to allow time for interpretation. The slides will be somewhat wordy in order to facilitate the interpretation that's occurring. We're going to highlight the role of the patient family-centered medical home. We're going to talk about the fact that care coordination is relational. And then we're going to talk about the care conference as a tool for care coordination. If I'm speaking too quickly or not allowing enough time for interpretation, please someone interrupt me and let me know. Most of you who know me know that talking slowly is a real challenge for me. So first, let's start talking about why we're having this conversation and about the challenges for families taking care of children with complex health needs. So in multiple surveys, families have reported feeling abandoned by the healthcare system. More than half the families report sometimes having to quit work in order to pay for care for their child, and almost 2/3 of families talked about having money problems as a result. Families also share that they have unmet needs, including having trouble getting to see a subspecialist, especially dental care and mental health care, having trouble working their way through the medical system, and having trouble finding help for the financial problems they're experiencing. Almost half of families are very dissatisfied by the medical services. They feel that communication can be poor, that two people might be doing the same thing, that it's hard to coordinate all the appointments and why can't they happen at the same time so that they don't have to travel or miss work. And there can be limited access to services in their community. In addition, families describe high stress in the family, not only financially, but also emotionally. People can feel isolated, and they can feel like they have no power because things are so hard to navigate. People can have high rates of depression or worries like anxiety. Siblings can have distress because there's so much attention that needs to be paid to the child with complex medical needs. People can be mourning what it feels like to have a child with increased medical needs. And there's risk for child maltreatment and marriage problems. There's risk for job loss or missing a lot of work, or even for some families, bankruptcy. And people can have trouble getting their own mental health needs met as a parent and getting respite care so that they can take a break to help with their mental health. So one solution has been to create what we call the family-centered medical home. And this is a comprehensive primary care that is a partnership between empowered and informed families and prepared primary care physicians like myself. In the family-centered medical home, care is accessible, it's continuous, it's comprehensive, it's coordinated, it's compassionate, and most importantly, it centers on the family. In addition to having the primary care provider, or PCP, that's what it stands for, primary care provider, that's your doctor. There is also, as part of the team, interpreters if needed, mental health specialists, receptionists and administrative people, and for care coordination, a social worker or a nurse care coordinator. And together they function as a team to support the patient and the family. The goal is to have quality and safety in the care. Family-centered care is about meeting families where they are and helping them get to where they want to go. Why is family-centered medical care and a medical home important to families? Families tell us it's because of the opportunity to build a trusting and collaborative relationship with the pediatrician and office staff. It's because care coordination allows smooth facilitation amongst all members of the child's care team, so including the family, any specialist doctors, pharmacy, and school and community services. And because it can be a comprehensive, a full and complete source of the patient's medical history. So what is care coordination? So when we talk about care coordination in a family-centered medical home, what we're talking about is helping to connect children and families to the right services and resources in all areas of the child's life, not just their medical care. Care coordination means helping to coordinate and communicate among these various services, including the non-medical services, to improve the health of children. So who benefits from care coordination in the family-centered medical home? All children benefit. This is good for everybody, but it's especially good for children who have high medical needs, who use a lot of health services, and for children who require medical technology. So often we call these children and youth with special healthcare needs. Their needs can be medical needs, sort of traditional medical needs, but they can also include complex psychological needs. so emotional needs, and complex social needs. And these are children who have lots of different services and care providers. I've listed some examples of children who benefit, and I want it to be noted that some of these children have things that fall more under the psychological realm, some of them under things that are more in the medical realm, but often these things intersect and they are a multitude of needs that are both medical, psychological, and social. The need for communication can be a lot. The goals of care coordination are to provide that integrated, connected care, as I said, by being patient and family-centered, but also about being proactive. So thinking ahead as to what might be needed and making sure that we are being comprehensive, including everything in the plan. We want to be promoting self-care skills and independence for the family. So families learn how to do things and are not overly reliant on other people. And we want to emphasize cross-organizational relationships. And this allows well-being and the best health for children. We want in care coordination to connect children to services, to facilitate communication between those services, and in the medical home to support families as primary caregivers. So making sure that families who are doing all the work really are getting the support that they need. As I said, we want to make sure that we're paying attention to the interrelated medical, social, developmental, behavioral, educational, and financial needs of a family. And care coordination should benefit at every level of the healthcare system, including improving delivery of services and decreasing the family burden, and thereby reducing healthcare costs and utilization. Importantly, care coordination is not the same thing as case management. Case management primarily focuses on the child's main issue. Case managers work with and guide services intrinsic usually to their specific agency, as opposed to care coordinators who work with and guide the team process, which includes and is driven by the needs of patients and families for services across the community. Care coordination includes care planning and building that collaboration and partnership with all medical and non-medical providers working with the patient and family. Importantly, care coordination is relational coordination. So relational coordination is defined as a mutually reinforcing process of interaction between communication and relationships carried out for the purpose of task integration. This is a complicated way to say that when you know each other, it's easier to talk with each other, and you have more ownership to make sure things get done. If I've met you and I know you, it's easier for me to call you, connect with you, reach out to you. It's easier for us to work together. Successful care coordination takes into consideration the continuum of health, education, early child care, early intervention, nutrition, mental, behavioral, emotional health, community partnerships, and social services, as well as payments for these services, needed to improve the quality of care for all children and youth, including those with special healthcare needs, while acknowledging the importance of language and culture in achieving desired outcomes. So now let's move on to talking about the care conference. We understand the importance of care coordination and communication across sectors. And so now let's talk about how to make sure that's happening. So a care conference is a tool to make sure care coordination is happening. It helps the family have all the care providers in one space, having one larger conversation together with them. It can address family and child concerns. Care conferences help identify who's doing what or their care roles. Care conferences help to avoid two people working on the same thing, so there's no duplication of services. Care conferences help to find out what's not being done, what's missing, what should be happening. Care conferences help with communication challenges, misunderstandings. And care coordination facilitates that relational coordination. It allows us to know each other, so it's easier for us to work together as a larger team to support a family and child. The medical home usually takes the lead for organizing care conferences. Many of you may work in the educational sector or have familiarity with the educational team, who usually organizes the individual education plan or IEP, a 504, and EST meetings. These are meetings that help to get children in school the extra supports they need. And as I say this, reminds me of the importance of defining all of the short forms we use in both medicine and school, because this can be hard for families to know what we're talking about. There are other meetings that happen called Act 264 meetings, and these are usually organized by the school or the Department of Children and Families, but they're not organized by the medical team. The care conference, usually organized by the medical team, is set up by the nurse care coordinator or social worker in the medical home. When do care conferences need to happen? They need to happen when there is a need to clarify the care plan. And this is especially true when there are newly identified needs or changes in the needs for a child or family. We can expect there to be changes whenever there's a transition of medical care providers. And so meetings are important during transition times, whether that is the medical team, community supports, or educational teams. Care conferences also need to happen if there's a concern about duplication or missing services. And in general, even when there is no change or transition, care conferences should happen every year or twice a year just to check in, review, revisit, and reaffirm the care plan. To touch base, as we say. Care conferences should also happen when the family, medical team, education team, or community support teams request one. So they are not only happening because the medical team or family says there's a need, they can happen because the education team or community support team says there's a need. I want to give an example of a time where a care conference would be needed. So in our example, we have a 3-year-old girl who has the diagnosis of autism. Autism is an illness that affects people's speech and learning to talk, and affects a child's social skills, so their ability to connect with other people. This 3-year-old is transitioning from Children's Integrated Services, who provide support to children under age 3, to the school system, or what we call EEE, Early Educational Enrichment, which provides supports to children 3 years of age and older. So this is a transition time. Her last care conference happened after her diagnosis with autism spectrum disorder, and she has not had a care conference in between. There's going to be a lot of changes happening because she is switching from one care team service, Children's Integrated Services, to the school team. And it's important to have those teams pass information one to the next and to support the family. There may also be concerns that the family needs more supports than they are currently receiving, and this would be helpful in having a care conference. Most of the time, care conferences happen in the medical home, but they do also happen in the hospital setting when a child's being discharged. And this is something at our institution we're working on doing more. So when a child is getting ready to go home, have the hospital team, the primary care doctor team, and the community and education supports all have a meeting prior to the child leaving the hospital. Care conferences can happen in the in the family's home. And I do many care conferences in the family's home, especially if it is difficult for the family to leave their home with the child. Care conferences can also happen at a community agency or at the school. The coordination, however, is provided by the medical home. Right now, care conferences are happening on Zoom because we're unable to all get together in one place. And these have actually worked quite well. In fact, I think for a lot of people, it has meant that more people have been able to attend the care conference because they don't have to have time for transportation to another setting. So when it's been determined that a care conference would be helpful, the next job is in setting up that care conference. Care conferences usually are about an hour long. And so once there is determined to be a need, the nurse care coordinator or the social worker will coordinate with the family. They will determine who should be invited to the care conference, set a date for the care conference that works for the people who need to be coming, set a location for the care conference, and then shortly before the care conference, send out a reminder about the date and time. So who is invited to the care conference? The child and the youth caregivers are invited. And the child or youth can attend, but it's not required that they attend. If a family would prefer their child is not there, that's fine. The primary care provider attends, as well as the nurse care coordinator or social worker who sets up the care conference and is supporting the coordination. But who else should come? Ecomapping is a tool that helps to identify who else should be invited to a care conference and who else is involved in the child support system. A nurse care coordinator or social worker can sit down with a family and ask them questions about their medical team, school team, home supports, community supports, mental health supports, and any other supports like a pharmacist or dentist, technology support, or maybe even a traditional healer, an elder who helps to make family decisions. And they can be then invited to participate in the care conference if the family wishes. The exercise of eco-mapping is also very helpful for understanding who maybe isn't part of the child and family support team, but should be. Because it allows understanding the strength of the relationship with all members or lack of relationship. Perhaps this family is not connected to the Vermont Family Network. Perhaps this family does not have a visiting nurse for the home, but should. Perhaps there is no children with special health needs social worker. And eco-mapping allows us to determine what's missing or what relationship needs strengthening, as well as what relationships are strong and working for the family. So it identifies team members and also the relational components of that coordination. These are two examples of care maps pulled from the internet, one done schematically on a computer program and one written out by hand. But they help to illustrate how many people and all of that coordination and communication that needs to happen around a child, especially a child with special healthcare needs. So once we've determined our date for our care conference and our setting for a care conference, we gather, whether in one setting like our conference room in our office or over the internet through Zoom. The care conference always starts for us with reviewing interpreter rules. And interpreter rules help to make sure that all members of the care team who are present, who may not have as much experience working with interpreters, understand that we need to speak directly to the limited English proficient patient or family member and use first person. To make sure the interpreter has enough time to adequately interpret all communication. To make sure that there's no side conversations that don't include the family. And to remind us to keep our questions and statements short and simple. To remind us not to use technical terms and slang or abbreviations. To break up ideas that might be complicated into simpler ideas. And to allow the interpreter to remind us if we forget to slow down. Then we usually do brief introductions and remind everyone about confidentiality. Confidentiality is important, and so we ask for a release of information to ensure that the family agrees to communication between different providers of the care team. We cannot communicate without this release of information because the confidentiality or privacy rules for medical providers and education providers are different. HIPAA is the confidentiality rules and privacy rules for the medical providers. FERPA is the privacy rules for the school teams. Without a release of information, we cannot talk to each other. We remind families that the care conference is a confidential space and that information shared will be kept private unless we have permission to share from the parents or caregivers. An agenda is set, and this is an example on the sample note template of our usual agenda. And we have someone take notes and fill in this agenda. The agenda is driven first by the family, and then care team members will also share celebrations and concerns. So as we have been talking, everything is family centered, including the care conference. So first, the family will share any celebrations or concerns about their child. What has been going well, what they're worried about, what they need help with, what is most important to them to discuss during this hour. After they have shared, then the medical team, school team, and other services will share information with the family and the full care conference. Everyone acknowledges the child's strengths and the child's challenges. It is important to encourage the family to ask for clarification, to ask questions, and to advocate and negotiate. The picture here in blue is of something called Ask Me 3. Ask Me 3 is a teaching tool to help families make sure that they are getting the information that they need. The first part of Ask Me 3 is for families to know what the main problem is. The second piece that families should know is what they need to do. And the third piece that families should know is why it is important for them to do that. Whatever it is, why is it important? So during the care conference, we want to make sure that when we are giving information, we are explaining the problem, what a family needs to do, and why it's important to do that. Let's visit our case example again. Our 3-year-old with autism who is moving from the Children's Integrated Service supports to the school supports. So for this care conference, we would review the interpreter rules if we were using an interpreter. We would discuss confidentiality, and then we would introduce everyone attending the care conference to each other. People would give their name and their connection to our 3-year-old and what service they provide. What is their role? We would then have the family talk about their concerns and their celebrations. So they might share that they've noticed that their daughter is speaking more and that they're very happy about this. They might share also that they want to get services still in the home as they have been with Children's Integrated Services, because they have concerns about getting the child to school. They might also share that they have been feeling very alone and that this is maybe worse because of COVID, but that they don't have a lot of social connections. Next, the school team, the new school team, might share what will happen at school. They will describe what supports, like speech language pathology, or SLP as we say, will be involved. How often will speech be supporting their child? How many times a week for how many hours? They might describe what they will be doing, what kind of play, what kind of learning will happen to help with language and social skills. They will answer family questions about transportation and connection. The medical doctor might then clarify what autism is, if there's any misunderstanding, or review that diagnosis with the family, and talk about any other challenges medically that the child might be having. The social work team might then commit to exploring community supports to help with transportation or the isolation that the family is experiencing. All decisions are made through shared decision-making. Families and youth, children, have a fundamental right to understand all options available for their care and the arguments for and against each option. Shared decision-making is what we call this. So this is when families, youth, and pediatricians are all involved in decisions about treatment. When we share things openly, all the information is shared openly. Everyone gets to express their opinion or preference about the treatment, including the family. And then there is a negotiation and a mutual agreement about the plan moving forward that the family and the care conference team agree upon. Shared decision-making is one of 6 priorities for patient-centered care. And when we use shared decision-making, we reduce healthcare costs. So in our example, with our patient, We let them drive the conversation with their concerns. And when we make plans, we want those to be made so that they support the parents and the parents are in agreement with those plans. With that shared decision-making and that agreement, we create something that we call the actionable shared care plan, or the things to do list. So out of the care conference, action items to do, things we need to work on are identified. And they're also assigned. So someone takes on the responsibility. For example, the social worker says, I will look into a bus. I will look into a play group. They take responsibility for doing that part of the plan. Because there are multiple care conferences that can happen, there can be a shared care plan that is an overall summary, and that can be updated based on the care plan from this care conference. At the care conferences, any follow-up visits or conferences with specialist physicians or the school would be announced so the family knows what's coming up. The next care conference would be scheduled at that time when everyone's present, so it's easier to find a time that works for the family and all the other members of the support team for that child. And then the template note that I showed you earlier, that has been being filled out, and that is then shared, as long as we have family's permission, with everyone there. That way everyone leaves knowing when the next care conference is and knowing what the plan moving forward is and who is doing what to support the family. A shared care plan is important because it builds community collaboration and communication across services. The education team, the medical team, the community service teams all have this shared plan together. It also allows the family and members of the team to build a base knowledge of services and systems of care. It helps to make sure that appropriate referrals happen and there's not that duplication or fragmentation of services. People aren't doing the same thing or not remembering to do something. It's complete. It helps to build the capacity of primary care to provide long-term chronic care management. And it addresses systems issues and barriers proactively, ahead of time. Things like financial problems, insurance problems, or access to care. These are examples of templates for shared care planning. And here is one example from the Lucille Packer Foundation that walks through the steps that we've just talked about. So in summary, the care conference is a facilitated, family-centered, 1 hour usually, meeting among the family, primary care, community providers, school, formal and informal family supports. The care conference facilitates detailed communication about strengths, challenges, current services, and gaps in services. and creates a coordinated plan of care with shared goals, resources, and workload distribution among providers, with family input and consent that informs the shared care plan. Care conferences address communication issues, needs of the family, and help to resolve identified and anticipated needs. Thank you. And we have about 15 minutes for questions. I really would like to answer any questions anyone has about how these work.
Thank you so much, Dr. Green. We do have a few questions in the chat that I'd like to read. But before we do that, we'd like to let everybody know that we are going to give you all the ability to unmute yourselves if you'd like to ask a question. We're going to be taking away the interpreter channel so that everyone could ask a question. And please allow for time for each interpreter to interpret the question. And then Dr. Green, they will each take the opportunity to interpret back after you respond. So while that is happening, I will ask one of the questions. One of the questions in the chat is the care coordination something that is available in adult services or for adults?
अनि एउटा प्रश्न च्याटमा छ यो
waqtigan waxa waaye waqtigii su'aalaha isweydiinaya soo wax su'aalaha haddaad haysiin soo sii daaya.
So yes, I know that through the UVM Health Network, there are adult care coordinators, just as there are for children.
अनि बच्चालाई हाम्रो युभिएमबाट पनि त्यो एडल्ट केयर कोअर्डिनेटरहरू हुनुहुन्छ बच्चालाई मात्रै हैन जवानहरूलाई पनि यसले सहयोग गर्दछन्.
They are not necessarily in each clinic like we have in pediatrics. So the setup is different, but they're working towards being similar to what we do.
Ashok and Fatuma, one moment. Ashok, could you please interpret Dr. Green's response? And Fatuma, after he's finished, could you please interpret? We've taken away the interpreter channels so that everybody can hear. Okay, so why don't you go ahead?
विशेष यो केयर प्लान चाहिँ केयर कोअर्डिनेटर चाहिँ युभिएम हस्पिटलमा उहाँले पनि गर्दै हुनुहुन्छ. हाम्रो जस्तै ठ्याक्कै हाम्रो क्लिनिकमा जस्तै चाहिँ छैन, उहाँहरूले यसमा मिलाउँदै हुनुहुन्छ र जवानहरूले पनि यो सेवाहरू सुविधा पाउनुहुन्छ.
dadka waaweyn klinikooda meel kasta kuma yaalo laakiinse way jirtaa meel laga caawinayo sida ciyaalka yaryar maxay meel kastoo tigtidaa ka helaysa maha laakiinse mid maxay heer u gaara oo jirto way jirtaa haddaa rabtid maxay daktarkaaga u sheegaysaa oo kaa caawinayo ku sheega.
So just to summarize, this is something that's newish, but it is something that everyone is hoping to work towards offering families.
अनि यो चाहिँ छोटोमा भन्दाखेरि यो नयाँ कुरा हो र सबैजनाले यसमा परिवारहरूलाई यो प्रदान गर्ने यो सेवा प्रदान गर्ने कामहरू गरिराख्नु भएको छ.
maxay ahayd kani hadda waan bilaabayno wax cusub waaye laakiinse waxaan rajeynaynaa inaan saansi ka fiican sii samayno.
There's been a couple of questions around who would the care coordinator be and how do you find that person if it's not currently happening in the practice?
अनि केही प्रश्नहरू छ यहाँ. अनि केयर कोअर्डिनेटर भनेको चाहिँ को हो अनि को भनेर हामीले बुझ्ने अनि कहाँ पाइन्छ त्यो केयर कोअर्डिनेटर कुन ठाउँमा काम गर्नुहुन्छ यो बारेमा प्रश्नहरू छ
su-aasha waxaa waaye coordinatorka yaa waayo qofka u tegay sida uu sheegay sida inuu maxay ahayd familkaaga ama dadkaaga ay rabaan inay maxay meeting la sameeyaan haddii hadda waqti xaadirkan ay maxay dhakhtaradii clinicka ayna joogin
I would recommend that you talk to your child's doctor and ask them if they could set up a care conference.
अनि म चाहिँ के सल्लाह दिन्छु भने तपाईको नानीको डाक्टर छ उहाँसँग छलफल गर्नुहोस् अनि केयर कन्फरेन्स एउटा गर्ने भनेर पनि तपाईहरुले उहाँहरुलाई अनुरोध गर्नुहोस्
waxaan la hadlayaa ani haddii ahaan lahayd qolada maxay ahayd dhakhtarkaaga ilmahaaga dhakhtarkiisa aad dhahaysaan waxaan rabaa inaan care conference sameeyo iyadaa markaas ku caawinaysa xaggaas dagaalaysa
It may be that they don't have someone in their office, but they could still arrange a meeting with the doctor and school.
अनि अब उहाँहरुको क्लिनिक अफिसमा त्यो केयर कोअर्डिनेटर नहुन सक्छ बच्चाको लागि तर स्कुलमा उहाँहरुले कुराहरु गरिदिन सक्नुहुन्छ
waxaa dhici karayso inayna maxay ahayd xafiiskooda waqtigaas ahaantaas ayna ku haysan laakiinse maxay ahayd waxay qolada iskuulkii qolkaas ay kugu xiriirinayaan sida ay u saraf garayaan hadhowtooda
It may be that there is a nurse or social worker in the office who has this job, but it hasn't been recognized that your family would benefit from having their support.
अनि एउटा नर्स अथवा सोशल वर्करलाई नै त्यो जिम्माहरु दिएको पनि हुन सक्दछ तपाईको बच्चाको डाक्टरको कार्यालयमा तर उहाँलाई पुरा त्यो जिम्मेवारी दिइसकेको नहुन पनि सक्दछ तपाईले उहाँहरुसँग छलफल गर्नुहोस्
waxaa dhici karayso inuu qolo maxay ahayd nurse amba qof kale oo loogu talagalay meesha inuu xafiiskooda waqti ahaantaas joogo laakiinse inaan maxay loo malay inuu familkaaga una u baahnayn so maxay iyaga u teg oo u sheegay ka caawinaya markaasi
This is something that is new, and a lot of doctors think it will be too hard to make it happen. But once they start doing it, they realize how helpful it is, and they want to do it more.
अनि अब यो कुरा नयाँ हो अनि धेरै जना डाक्टरहरुले चाहिँ अब यो कुराहरु गर्न गाह्रो हुन्छ कि भन्ने ठान्नुहुन्छ तर बिस्तारै उहाँहरुले गर्दै जानु भएपछि यो एकदमै राम्रो गर्दै रहेछ यो प्रभावकारी छ सबैलाई उपयोगी छ भन्ने बुझ्नुहुन्छ अनि यसलाई अझै गर्दै जाउँ भन्ने उहाँहरुलाई लाग्छ
When we first started doing this at UVM, there were just a few doctors who did it. And now every doctor does it, and the school and the families, they like them and they ask for them more.
अनि पहिला हामीले युभीएम हाम्रो यहाँ अस्पतालमा हामीले सुरु गर्दा चाहिँ एकदमै थोरै डाक्टरहरुले मात्रै यसलाई सुरु गर्नुभयो तर अहिले चाहिँ प्राय सबै डाक्टरहरुले यसलाई लिइराख्नु भएको छ गरिराख्नु भएको छ अनि स्कुलहरुले पनि यसलाई अझै मजाले गरिराख्नु भएको छ
waxaan iminka wax cusub waayo hadda aan fiirinayno so waxaa u malayaan dadka qaarkiis inuu weli dadka u shaqaynaynin oona caawinaynin laakiinse adiga maxay kolay kolba haddaa u baahantahay inaa u tagtid oo weydiisad oo u sheegtid waaye daktaryaal badan oo hadda sameeya way jirtaa oo fiiriyey laakiinse waxaan ku dhihi lahaa adi u tag oo u sheeg qoladaada maxay say kaa caabisa dhintooda